Good afternoon. It's my pleasure to introduce the Hoffman-Ratson Grand Rounds today. The Hoffman-Ratson Lectureship was established in 2005 by grateful trainees of Drs. Thomas Hoffman and Dr. Kenneth Ratson, who headed the ID training programs at Jackson and Mount Sinai Hospital in the 1970s and then ongoing since then. Until fairly recently. Dr. Thomas Hoffman received his medical degree at the University of Pennsylvania before completing his fellowship in infectious disease at the University of Rochester and was chief of the Division of ID at University of Miami from 1970s to 1988. And Dr. Kenneth Ratson completed his medical degree at Harvard Medical School before residency training at Columbia Presbyterian and ID fellowship at New England Medical Center Hospitals in Boston. Dr. Ratson was chief of infectious disease at the Miami VA in 1972 before moving to Mount Sinai, where he served as the chief of infectious disease until June of 2020. Dr. Hoffman and Dr. Ratson's expertise was widely recognized in the community, and they both set very high standards for their trainees. And we are honored to have Dr. Ken Ratson with us here today. And as a former fellow trainee of Dr. Ratson, I can confirm that he is a brilliant and elegant clinician in a way that as a fellow was always just a little bit intimidating. As I knew that when I presented a case, no matter what, he would always add one more aspect to my differential, no matter how much I thought I had prepared beforehand. This visiting lectureship was established to bring ID physicians from around the country to the University of Miami to honor the tradition of clinician scholarship set by these outstanding leaders. And so it is appropriate that we have Dr. Sandra Nelson, an expert ID clinician, with us here today for the Hoffman-Ratson Grand Rounds. The chief resident will now introduce Dr. Nelson. Thank you.
Good afternoon, everybody. Dr. Nelson is the clinical director of the Division of Infectious Diseases at the Massachusetts General Hospital, and she's also an associate professor of medicine at the Harvard Medical School. She completed her medical schooling at the Duke University before completing her residency in internal medicine and pediatrics at the University of Michigan Medical Center. She then completed her fellowship in infectious diseases at the Johns Hopkins University before joining faculty at MGH and Harvard Medical School in 2007. Dr. Nelson wears many hats, including but not limited to Director of the Program of Outpatient Parenteral Antimicrobial Therapy, OPAT, and co-director of the highly acclaimed Harvard CME course in infectious diseases in adults. Her academic interest is in the care of patients with musculoskeletal infections, and as such, she directs the program of musculoskeletal infections diseases at MGH. And there she's actively engaged in clinical care, educational efforts, and research on the treatment and prevention of musculoskeletal infections. She was a delegate to the 2013, 2018, and currently 2025 International Consensus Meetings for Periprosthetic Joint Infections and is currently working on International Unified Periprosthetic Joint Infection Diagnosis Guidelines. She's a past president of the Musculoskeletal Infectious Society and is also a section editor for UpToDate in the areas of musculoskeletal infection and skin and soft tissue infection chapters. Dr. Nelson will be leading our discussion today on the topic of a joint endeavor, challenges of prosthetic joint infection. Please help me in welcoming Dr. Nelson.
Thank you so much for this tremendously warm welcome. Thank you to Dr. Doblecki for the invitation to be here. I know that several of you have sort of apologized for the weather, but to put this into perspective, in Boston today, it was 1 degree this morning with the wind chill. And if I were in Boston right now, I'd have on my long puffer, my wool hat, probably 2 pairs of gloves, 2 pairs of socks, and some snow boots, and I'd still be cold. So this is really, truly a privilege to be here. I have no disclosures. I will be discussing the off-label use of antibiotics. And the reason that is because there are essentially no antibiotics for whom there is an FDA-approved indication for the use in bone and joint infection. So much of what we do is off-label use. I am also really humbled and honored to be here in recognition of two of the giants of the field. And I think the further I am in my career, the more that I have come to appreciate the importance of the kinds of clinical mentorship that have really guided all of us. A lot of what we learn nowadays, we can learn through textbooks, we can learn through UpToDate, but we are really about the care of humans and the human connections that we forge as physicians. And those are the kinds of lessons that can really only be imparted by people who have been in the field for a long time. I too have had my own giants that I have really benefited from. Dr. John Bartlett, Dr. John Mann, both from my fellowship time at Johns Hopkins, Dr. Steve Calderwood. And these are people that have really molded me into the person that I am today. And it is really, truly, deeply humbling to be here in honor and recognition of two people who have served that role for so many of those of you here. I was asked today to speak about prosthetic joint infection. I am going to speak about it. I will say that I'm also going to use it as more of a example to think about how we approach infections that involve devices in general. There is a small amount of data in each of these areas, but there's a lot of similarities in how we think about them. Why prosthetic joint infection? This is something that has really only been around since the 1970s. Arthroplasty is a remarkable intervention that has come about in the last really 100 years or so. Osteoarthritis has really been around since as long as we really have any archaeological and fossil record. In fact, archaeologists have used the appearance of osteoarthritis, the localization of arthritis, to really inform them about the activities and mobility of our ancestors. I look at some of this old archaeological data to really say, gosh, our ancestors were in a lot of pain. And so as a consequence of that, really once medicine evolved, there have been efforts to try to solve the problem, the pain and the mobility issues that are associated with arthritis. The first attempts at arthroplasty occurred in the late 19th century. There were some reports out of Germany in the late 1800s where surgeons attempted to use ivory to replace infected total hips, not particularly successfully, but it was one of the first examples of that. Also, around the same time, there was an effort to put tissue in hips that were arthritic, because the pain is oftentimes associated with that bone-on-bone contact that occurs. And if you can put something to prevent that bone-on-bone contact, theoretically, you can improve the pain that's associated with this. So this is called interposition arthroplasty. And surgeons at the time used things like human skin and human tendon tissues and even pig mucosa, so early xenotransplantation, to try to improve that. None of that was particularly successful. In the 1920s, the first sort of precursor to the modern arthroplasty device was generated based on a mold. It was constructed out of glass, and there was a glass device that could be essentially placed on top of a femoral head. Challenges were that once these devices were placed, they had a tendency to break inside the human, and so you could imagine that that was not a particularly successful approach. Modern arthroplasty is largely characterized from the 1960s forward. The father of modern arthroplasty, Dr. John Charnley, is a British orthopedist, and he really experimented with different approaches until he came upon a structure that included a stainless steel intramedullary device, a high molecular weight polyethylene liner that is currently used in the acetabular structure, and then glue, cement as a glue to kind of hold everything together. And those are the components that really were used to make hip arthroplasty in the 1960s and really continue to form the framework for the devices that are in use today. Since the 1960s and 1970s, there have been an enormous number of improvements on these early arthroplasty devices, but the structures are similar. They're usually some kind of a stainless steel metal framework, some kind of high molecular weight polyethylene, which serves as somewhat of a cushion, so you don't have metal on metal articulation, and then cement to glue it together. And those are still the devices that are in place. And there have been many changes in implant design, in understanding of biomechanics, and these devices are now really quite miraculous. They are long lasting. Patients who have them placed oftentimes have them in place now for 20, 30, 40 years, really for the duration of life. And this has led to tremendous quality of life gains. It has been called, total hip arthroplasty has been called the orthopedic operation of the century. I think there are the last century. I think there are very few orthopedists that would actually disagree with that statement. This is really miraculous. We are now at the stage where there are about 10 to 15 million, we don't quite know, individuals in the United States that have arthroplasty devices in place. Something like 10 to 15% of individuals at the age of 80 have arthroplasty devices in place. Statistically, there's probably one of you in this room, one or maybe two, that has a device in place. So these are quite common. And now we see them not only in hips, but we see them in knees, ankles, shoulders, elbows, wrists, and even the digits of the fingers, the interphalangeal joints of the fingers and the toes. There's been a tremendous growth because these devices have been in part so successful. There's been a tremendous growth in the use of arthroplasty over the last, really, I'd say 20 to 30 years. We're still on a phase of growth that hasn't reached a plateau. When I started giving lectures like this, we were told that approximately 500,000 to 700,000 arthroplasties were placed. Primary arthroplasties were done in the United States. We think right now we're at about 1.5 million. Year over year, we're increasing between 5 and 10% in terms of the number of primary arthroplasties that are in place, sort of doubling in use about every 10 years or so. It's a $20 billion annual business. It is phenomenal. And that number is going up by $1 billion or $2 billion per year. Why is that? Well, there are a lot of reasons. I think the most important is this is an incredibly successful procedure. It takes individuals who have significant pain and loss of mobility and restores them to a high function, high quality of life. We also, as you know, have an aging population, and we are doing a better job of controlling their comorbid conditions, and that leads to more people who are living longer periods of time in order to generate the kind of arthritis that would then inform the need for arthroplasty. But I think a big part of this is also that we're expecting more as we get older. So it used to be 100 years ago that once you reached a certain age, you sort of could put your feet up and really enjoy your golden years in a chair. And now people in their retirement are really many are hoping to remain active. And we have people with arthroplasties who are climbing mountains, who are running marathons, playing pickleball. So we're really using our bodies in ways that we didn't into our senior years. So I've shown you that we're putting more and more devices in people over time. And now we're going to talk a little bit about prosthetic joint infection and why we're even talking about this. About 1 to 2% of individuals who have a joint placed will develop an infection over the course of their arthroplasty life. We think this is probably a little bit of an underestimate, but these are the standard numbers that are reported. Now, there hasn't been much change in this over time, despite these tremendous advances in the techniques and the surgical procedures and the devices that are used, important surgical modifications over the last number of decades. We haven't really been able to get the risk of prosthetic joint infection down to a level where it becomes minimal. It still kind of hovers at this stubborn 1 to 2% range. There have been some important interventions that really improved the risk about 10, 20, 30 years ago, and those include the use of surgical antibiotic prophylaxis, as well as testing individuals for Staph aureus colonization and decolonizing those that are positive for staph before surgery. And these have had important and noticeable improvements in the PGI risk profile. But these improvements have in part been offset by the use of devices in higher risk persons. So now it used to be that we would put arthroplasty devices in people who were reasonably healthy and fit, and now they're being used more and more in people who have intrinsic risks for arthroplasty infection. That 1 to 2% risk, which is widely quoted, however, is really not the risk that many individuals face. There are certainly medical risk factors, patients with diabetes, patients with obesity, chronic kidney disease, who have higher risks for periprosthetic infection. There are anatomic risks for reasons that I don't quite understand. Some studies suggest that there is a higher risk of infection if you have a joint replacement on the left side as opposed to the right side. What I've been told is that this has something to do with the surgeon's position in the operating room and their comfort in operating on a side, on a less traditional side. And then there are other factors. Substance use disorder is a tremendously high risk. And of course, this has become a big problem of late. And patients with substance use disorder have a higher risk of developing septic arthritis that can lead to dramatic joint collapse and need arthroplasty at younger and younger ages. I also want to highlight that we are just beginning to understand that there are other factors at play, including structural factors. And there's not, the burden of periprosthetic joint infection is not really distributed equally amongst all individuals. There are higher risks in certain populations, some of that perhaps related to underlying comorbidities, but there are probably other factors at play as well. I'm showing you a study here that was performed by a new colleague of mine, Dr. Pinkney, just joined our faculty after having finished her fellowship in our program, who has really been a champion of health equity and asking us to think about risk factors differently than what I had been trained to think about them. And so she looked at our experience in the MGB system, which includes the Brigham and Women's Hospital, over the last 20 years or so, and we found that Black men had a threefold higher risk than white women in developing a periprosthetic joint infection. We don't know why that is, but nonetheless, I think these are things that we're going to need to untangle. I also just wanted to share that Dr. Pinkney was turned on to infectious diseases during a observership that she did while she was I believe, a medical resident at Jackson Memorial Hospital. So she's been a real asset to us, and just thank you to any of those in the room who helped to turn her on, because she's just a real treasure. I mentioned a little bit about the impact of periprosthetic joint infection, and I don't know if any of you in the room have cared for these patients, but this is an incredibly, incredibly challenging and morbid problem. Certainly, there is a tremendous economic burden. Some people put the number about $2.5 billion per year that this costs us in the healthcare setting, and then sort of for loss of economic productivity. But I think from the patient perspective, these are painful. And these are people who undergo surgery to eliminate pain and to restore function. And instead, the prosthetic joint infection sets them back such that they have pain again and they have loss of function. And I've had many patients that have told me that if they had known, they would never have had the arthroplasty in the first place. They are not as well off as they were before the arthroplasty. And then there's important psychiatric comorbidities, a high risk of depression and anxiety that are associated with these conditions. They're also associated with mortality, and this is something that I think the orthopedic community is looking at quite closely. For people who undergo arthroplasty and then develop a prosthetic joint infection, their 10-year mortality is about 5 times higher than those who don't develop an infection. Not everybody, this is not all attributable mortality. Some of this is related to the underlying comorbidities, but it probably also relates to the fact that patients with prosthetic joint infection lose mobility, and mobility is very important in terms of longevity. A recent study quantified the risk of mortality in patients with prosthetic joint infection and put it at 25% within 5 years. That is to me, it's striking. It actually is more than we see with certain cancers. It's a sort of similar to people with breast cancer and higher than individuals with lung cancer and colorectal cancer these days. So this is a very high risk, high burden problem. I'm going to shift and talk a little bit about why these are so difficult to treat from an infection standpoint. This phase of my discussion is really going to be relevant for types of device infections outside of arthroplasty as well. We are putting more and more devices in people, and these devices are getting infected. We are putting intracranial devices in place. We are putting cranial implants to cover bone defects in the skull. We are using vascular grafts. We are putting fixation devices in to realign feet or to fix fractures, and all of these can get infection. The mechanism of infection in relation to devices, though, is a little bit different. than the types of infections that we think about causing infections in our native tissues. And that's because of a structure called biofilm. So biofilm is something that is really ubiquitous in the microbial world. And biofilm consists of what we call these microbial communities that live together. These microbes are living together within a construct, a polysaccharide matrix, a slimy matrix. And that construct adheres to the surface of a device and protects and nourishes the organisms. These organisms produce this slime, and it really is called a slime. And actually, there are many analogies in common everyday experience that we can use when we talk to our patients about why this is a problem. Some people like to think about, some people in the biofilm science world actually like to shift the way we think about this. We oftentimes think of bacteria as unicellular organisms. But in biofilm, they're actually working synergistically. The organisms within the biofilm are working synergistically. They've differentiated with different tasks and roles within the biofilm such that biofilm scientists sometimes refer to them as multicellular organisms. Now, biofilm can be produced by any number of organisms, including bacteria and yeast and molds and algae and many other types of organisms. And they can be produced by, they can consist of either one type of organism, monomicrobial biofilms, or different species all within the same biofilm, polymicrobial biofilms. Although different organisms have different propensity to form biofilm, but essentially any organism can become in biofilm. Now, when I talk to patients, I oftentimes try to use examples in the world about biofilm, because this is not just a problem in the human body. So if you're ever crossing a river or a stream, biofilm tends to form in wet settings because the bacteria that are present within water will, as the water is being propelled through currents, will find a place to stick and adhere. So if you're ever hiking and you cross a river and the rocks are really slippery, that's biofilm that's on the surface of the rocks. Certainly, it's present in many industrial settings. It's a real problem in the shipping industry. Biofilm essentially coats the bottoms of many ships. This is a naval ship in dry dock. And it's also a problem in food industries because it's very easy to contaminate the equipment that is used for generation of food. This is from an industrial dairy farm. So this is tubing that contains the milk that is flowing from the cow into the industrial facility, and this is really covered with biofilm. And this is one of the reasons that we sometimes see food outbreaks associated with these biofilm. So how many of you, I'm just going to do a show of hands, how many of you this morning brushed your teeth? Oh, good. Okay, I've just sort of check is everyone listening. So how many of those who brushed their teeth used a new toothbrush? Show of hands. Okay. Oh, one. All right. Well, the rest of you brushed your teeth with biofilm because biofilm is on the surface of your toothbrush. This is what you're seeing on the left. How many of you had a cup of coffee this morning? Okay, good. So biofilm also is within the water canisters of our coffee cups. These are a couple of home Keurigs that contained biofilm on the basis of the canister. So congratulations, you drank some biofilm this morning. For those of you who are not coffee drinkers but drink water from a bottle, how many of you washed your water bottle in the last 24 hours? Oh, several of you did. The rest of you are drinking biofilm. So enjoy. And this is actually fine and it's healthy. We have more bacteria within our bodies than we have human cells. And we are constantly replenishing our microbiome, or we're constantly exposing it to the organisms that we're consuming. So it's not to say that this is a problem, but it's present and we should acknowledge that. The challenges from the standpoint of devices is that it is extremely easy for biofilm to develop. When a surgeon operates, they use standard surgical antisepsis, and the goal of that is to reduce the burden of bacteria on the surface of the skin. But it is never sterilizing. No matter what we use, there are bacteria that live through the surgical skin antisepsis. And once they can get into a surgical site, usually it's not a problem. But if there happens to be a device in place, the organism may choose to adhere to that surface and then begin to establish biofilm. And that process can occur within minutes of the bacteria entering into the site where a device is placed. Once that lands, once it adheres, the process of biofilm development really proceeds rather quickly. And biofilms will develop and mature over a few hours to days to really 2 weeks. And by 2 weeks, we call a biofilm in general mature. Now, we also, in the setting of infection, we think about these organisms like Staph aureus or E. coli or Pseudomonas as the real problems that we face. But many organisms can cause biofilm, including things that we don't normally think about as causing infection, like coagulase negative staph or Corynebacterium or Cutibacterium. And yet these organisms are some of the most challenging for us to treat when they form biofilm. So we see these organisms causing infection in settings in which you otherwise wouldn't expect it. Organisms within biofilm, and I'll talk a little bit more about why this is, are essentially intrinsically resistant or are resistant to the host defense system, which is really our primary defense, as well as antibiotics. And so in general, there has to be manual liberation of biofilm in order to eliminate them. So this has been recognized, really for many years, and I wanted to highlight that this was also acknowledged by Dr. Ratzen, who made a report in 1982 of patients who had had cerebellar implants placed and became infected. It was a small series, 14 patients, but probably the largest series at the time, of whom the 12 patients who had their devices removed did well and were cured, and the 2 that didn't, one of them had prompt recurrence, which really argues again for the importance of device removal. And thank you to Dr. Ratzen for his work. Well, one of the things that I'm often asked when I see patients with device infections, prosthetic joint or otherwise, is, can't I just take antibiotics? Won't this just go away? Patients will go to their surgeon before surgery. They check the informed consent. I understand that there is a risk of infection, but what they assume is that they will just be able to take some antibiotics and that infection will clear, as it would if you had a pneumonia or sinusitis or a UTI. Traditionally, when we think about antibiotic resistance, all the ID physicians and fellows in the room will know a chart, like a graph like this, or a picture like this, or have seen others like it. There are these classic mechanisms of antibiotic resistance that we think about. The bacteria may alter its cell permeability such that antibiotics can't get in, or they have strategies where they may either degrade the antibiotic once it accesses the cell, or they may modify the antibiotic or the target. That's seen with beta-lactamases or altered penicillin binding proteins, which confer beta-lactam and methicillin resistance. And then there's efflux pumps as well. And all of these things are important mediators of antimicrobial resistance for traditional types of infections in which the organisms are not embedded within biofilm. But within biofilm, those mechanisms, while they're still important, become much, much less important. And what really leads to the antimicrobial resistance of biofilm is mediated at the population level. Many of you will know the term minimal inhibitory concentration, or MIC. So that stands for the concentration of an antibiotic which is needed to inhibit the growth of bacteria. And we use those numbers to determine if an antibiotic is active against a certain bacteria. Within a biofilm, you might have an organism that once you take it out of the biofilm is very sensitive. You can use a variety of antibiotics and it will be active. You put that same organism back into the biofilm and all of a sudden it's resistant. Functionally resistant. And there's this concept that is used, it's not available in any kind of commercial setting, but it has been evaluated in investigation called the minimum biofilm eradication concentration. And essentially, what we know is that those numbers are about 1,000-fold higher than the MIC. So you really need to barrage these biofilms with levels of antibiotics which are not safe for humans to receive in order to exert a meaningful antibacterial effect. The resistance is mediated, as I said, at a population level. And this is complex, and I won't go into great detail. We're still sort of understanding how it is that biofilms prevent the efficacy of antibiotics, which should be active against the bacteria that are contained within it. We used to think it related primarily to penetration. If you think about the slime that is, on the surface of that rock, for example, if you think about the muck when you pull a drain in your kitchen and that muck that's on the inside, all of that is biofilm. And you could imagine that it is difficult for molecules to really penetrate that. And that's what we thought was part of it. That is probably a part of it. It is certainly harder to eradicate the deeply embedded organisms than it is the surface organisms. But it really is more than that. And it is in part because organisms within biofilm undergo these phenotypic changes for a variety of reasons, and they become essentially metabolically inert. So rather than replicating and growing and doing the things that living bacteria should do, they just kind of become dormant. And when you think about the mechanisms of action of most of our antibacterials, they require metabolic activity. So if you have bacteria that are just kind of hanging out and not doing anything, the antibiotics aren't going to exert an effect. We're also learning more about what we're calling persister cells. So persister cells are cells that are genetically the same as all of the other organisms within the biofilm, if it's a monomicrobial biofilm, but yet are induced into this phenotypic state of inertness, especially when antibiotics are present. And fewer than 1% of cells within a biofilm are thought to be these persisters, and they become very, very quiet. And even if other organisms within the biofilm are eradicated by antibiotics, the persisters survive. And once the antibiotics are withheld, the persister cells can then repopulate in an infection. So there's a lot of work in the biofilm community about trying to understand the persister cells and how we can really think about eradication and new strategies for eradication. So really just thinking about biofilms, these are an evolutionary mechanism for the bacteria and other microbes in our microbial world to survive. When we treat them, or even with our own host immune defenses, we are really not able to effectively eliminate biofilm. There is resistance that is mediated by the population itself. And therefore, when we're talking about device infections, including periprosthetic joint infections, we really need to think differently about how we treat infection. So I'm going to talk a little bit about how we approach these. And I think this is also a paradigm for thinking about really any type of device infections. Medicine is becoming more complex, and more of the problems that we are trying to solve bridge disciplines. And this is a particular type of challenge that we really need to work collaboratively with our orthopedic colleagues, with our plastic surgical colleagues, to come up with a solution that we all think works best. Patients need to be included. There's not necessarily a lot of science that tells us very clearly what the best treatment approach is. So when we talk about periprosthetic joint infection, there are really two big categories of treatment. There's surgical treatment and there is medical treatment. And surgical treatment really is a necessary part of a treatment for joint infections if we aim to cure infection. Because as we learned, biofilm doesn't respond. Organisms within biofilm will not be eradicated in the face of antibiotics without some attempt to remove the organisms manually. So there is a menu of surgeries that can be offered to these patients. And this is also something that we can think about as a paradigm for other types of device infections. So first, we can offer no surgical procedure. That is essentially not a curative option. But it is something that we do on occasion offer patients who really would not be able to tolerate a surgery. And that is really the only category for whom this is relevant. One of the most common procedures, I think the most common procedure done in the United States, is called debridement, antibiotics, and implant retention. It's shortened to a DARE procedure. And this is essentially when a surgeon will open up the surgical site, do a full debridement, high-pressure irrigation, exchange components that are modular, so those that are easy to remove. In a hip arthroplasty, for example, that includes the acetabular liner, that polyethylene liner that sits underneath the acetabular cup, and the femoral head, which can be unscrewed in most cases from the femoral stem. Those are then exchanged, and then the patient is closed, and then we treat with antibiotics thereafter. One-stage arthroplasty is where, one-stage exchange arthroplasty is where the device in its entirety is removed, and during the same surgical procedure, a new device is placed. That is a procedure that is not commonly done in the United States because there are not a lot of people that meet criteria for this. But this is done more commonly in Europe, where they use sort of a different type of surgical approach. And because surgeries are taught, the surgical approaches that are used in Europe continue to be used there, but have not really percolated into the surgical procedures that we use in the United States. And we're really still doing primarily this two-stage arthroplasty exchange, which is where a surgeon will go in, remove the infected device, irrigate, put in a temporary device, and I'll speak more about that in a minute. Then we treat with antibiotics, and then after the infection is cleared, the patient can then go on and have another permanent replacement. Realistically, we very rarely offer no surgical procedure, and in the United States, we're not commonly doing this one-stage arthroplasty exchange, and so we're really looking at a debride and retain approach or a two-stage exchange arthroplasty. I think if you imagine what this feels like from a patient, both of these are really pretty morbid to go in and really try to remove and clean out this infected area. It is very, very painful. The two-stage exchange procedure, however, really offers this unique opportunity to approach biofilm differently. And this is through the use of what we call local antibiotic delivery. And there are forms of local antibiotic delivery that we use in a variety of different surgical procedures. And essentially it involves, rather than the systemic administration intravenously, intramuscularly, or orally of antibiotics, it's use of antibiotics at a specific site. Sometimes it's simply a sprinkling of antibiotic powder into the surgical site, but oftentimes the antibiotics are mixed with a carrier. So I mentioned that modern arthroplasty really began in the 1960s, and really shortly thereafter, prosthetic joint infections were identified as an important problem, and strategies were developed to address them. What the surgeons first realized is that they had to take the devices out, but if they did that, patients would end up without anything in that space, in their hip or their knee. They'd have essentially a flail limb and be unable to ambulate. And furthermore, when they went to go put the device back in, the limb will have shortened such that they can't even fit the device back in place. So they constructed what they called spacers, and that was what they were intended to do, to fill the space. They're made of cement, and the cement is made at the time of the procedure. And sometimes there's a framework, a scaffold that the cement covers. As most commonly in the United States, there is a metal framework that is used, and the cement surrounds that metal framework. And the cement, this is cured at the time of the surgery. So the surgeon will step back, go to the back table, begin to polymerize the cement. And they realized shortly thereafter that if you put a little bit of antibiotic powder while you're mixing the cement, your monomers and your polymers, that once that cement forms this doughy state, it's then put back into the human host, that the antibiotic elutes, escapes from the cement, and it leads to a very high local tissue concentration that really works effectively. And the local tissue concentrations are really close to that magical minimal biofilm eradication concentration. So two-stage exchange procedures really allow an opportunity to use the mechanics of the spacer to then deliver antibiotics locally. So this is done as part of this two-stage exchange procedure. There are risks associated with it, and I won't go into great detail on that. And so when surgeons are really facing these decisions, there's lots of considerations that go into the decision point for what type of surgery to do. And it really comes down to DARE versus a two-stage exchange procedure. Now, the problem with a debride and retain is it is much easier on the patient, much easier on the patient. The patient is up and moving around usually within a few days of the surgery, but the cure rate when you don't remove everything is really pretty low. So cure rates in meta-analysis are probably around 60 to 70%, which leaves a large number of patients who go through this who aren't cured. And that leads to a large number of people who we end up putting on long-term antibiotics, which creates a whole host of other problems. The cure rates of the two-stage exchange procedure are much higher, around 90%. So much better. That's really our best curative procedure. But the morbidity associated with that is really profound. And so when facing this choice, you can either go through a low morbidity but low efficacy procedure or a high morbidity but high efficacy procedure. And these are both painful options for patients. And so oftentimes, we really don't know what is the best approach. surgically, it's been interesting to watch as an infectious disease non-surgeon, watching the surgical thought evolve. So there is this new approach. I told you about the 1-stage exchange procedure and the 2-stage exchange procedure. We now have a 1.5 stage exchange procedure, which, as you think about stages and counting, doesn't make any sense. But it is sort of a hybrid between this 1 and 2 stage, and they like the term 1.5. So 1.5 stage has stuck. And what this is built off of is the idea that an important minority of people who undergo the first stage of a 2-stage exchange procedure decide they're doing fine. Their infection is treated. They have this device in place. They're comfortable. They're able to meet their needs. Why would they go back in and have another surgery? So they ended up having these spacers that just kind of became their permanent devices. And when the surgeons realized that this worked, that these patients were doing well, they actually began to do this intentionally. And they created these spacer devices, which could be removed if needed, but also could be permanent if patients tolerate them. And we're still pretty early in this, but the cure rates are high. In fact, they're even higher than are associated with a 2-stage procedure. If you complete the 2-stage procedure, the risk is higher because the risk is associated with the second surgery. So if you don't go through a second surgery, you don't have that risk. So higher cure rates, not the same functional outcomes for people who are really demanding on their device, but for people who really just need it for their activities of daily living, this 1.5 stage exchange has really, I think, improved outcomes. So this is a picture of a destination spacer. This is a patient I cared for with a prosthetic knee infection. The infected knee is on the left and the destination spacer is on the right. You can see that there's not a lot of difference, at least radiographically in the devices, and patients are oftentimes quite comfortable. This is a destination spacer. You can see that we're still even using some of the same components that are used in a permanent arthroplasty. All right, I'm going to use the bulk of the rest of my time talking about antimicrobial treatment. And I'm going to do this a little bit philosophically. And when I think about how the approach to these infections has evolved over time, there has been a tremendous amount of research in the last 20 years as I've watched this field evolve. But the majority of the research that is done is not done in how to actually treat these infections. We have good research on how to prevent them. We're trying to develop these novel strategies, these novel implants, lots of research on how to diagnose them. I'm not even talking about that today. That's a challenging problem. Lots of studies that the surgeons are doing in order to optimize the management, but very, very little on how to take care of them. And when you think about it, there really isn't an incentive to do this kind of research. So if I have a minute, I'll just tell you, this is a conference, the Musculoskeletal Infection Society, which is a really wonderful interdisciplinary society, about 400 members, about half orthopedists, half infectious disease doctors. We meet once a year. We grow and collaborate. It really is a tremendous meeting. This year, they're usually about 150, maybe 200 people come to the meeting every year. There's always industry sponsors in kind of a room outside of the meeting proper. The challenge is nobody ever really goes to the industry sponsors. So this year, the sponsors, the organizers of the conference came up with this wonderful idea, which is that if you go to every table and the sponsors stamp a card, then we're going to put you in a raffle for an iPad. So I have an iPad. I don't need another iPad, but gosh darn it, I was going to go to every industry table and I was going to get my card stamped and I was going to enter the raffle. So I went to every table outside, and there were tables on surgical skin preparations, antiseptics, skin drapes that the surgeons use, irrigants, new diagnostics, which I think are really important, surgical tools, new surgical devices. Nothing on antibiotics or on the ways that we care for these patients afterwards. And it's just, I think, an observation and a frustration that this has been a very hard field to move forward. This is another device which was promoted at this conference. And in brief, this is a device that is meant to be used in a 2-stage exchange procedure to shorten the time between the first and the second stages and to eliminate the need for a cement spacer. And so they have these fenestrated intramedullary components here that you can see. I think, sorry, I know there's a mouse here. Does that work? You're able to see that right there. these fenestrated devices are placed and they're attached to this essentially a vac tubing, which can then instill antibiotics. And once a day for 7 days, you get local antibiotic delivery that is infused in this fenestrated device. At the end of 7 days, the device is removed. A patient can have their second stage procedure. This device costs $60,000. If it is ultimately approved, it is expected to cost $60,000 and will be used for a grand total of 7 days. And so there is a large randomized controlled trial that is currently being done to support the need for this device. And yet there is no science that's really being done prospectively in a meaningful way on antibiotics. So I would say in the field of orthopedic infectious diseases, we are really early in how to approach these infections. There have been very few randomized prospective studies. Most of them have been done in Europe, where the funding structures and the motivations for funding are different than they are here. Thankfully, there are some really great studies that are being done by our European colleagues. But there really remains a tremendous void of what I believe to be key data in how to approach these patients. There are studies, but there is not robust data that tells us what drugs to use, how to dose them, how long to treat, how to know when to stop, how to know to tell a patient that they're cured of their infection. We have none of that. And when I think about the metaphor of standing on the shoulders of giants, we are going to be building a very, very tall tower of giants before we begin to even answer some of these questions at the pace that we are going. I'm going to talk a little bit about some really, I think, important, fun updates in this area. Now, I'm probably older than most of you in this audience, but I grew up watching the Wizard of Oz, and I had nightmares about the Wicked Witch of the West. She was evil. She was underneath my bed at times. But, lo and behold, you learn now that she's actually this amazingly beautiful, wonderful, kind, compassionate, wounded, complex woman with integrity who just happened to be born green. And there's been this tremendous paradigm shift. The same can be said about antibiotics for the treatment of bone and joint infection. And it used to be that we really always used IV antibiotics for osteomyelitis. I would imagine that most of you, if I asked to raise your hands, would say the standard treatment for osteomyelitis is 6 weeks of IV antibiotics. Well, it turns out nobody really knows where this actually comes from. There really isn't any study that says that that's the case. When we look at this and trying to understand where this historical practice came from, there was an article that was published in the 1970s in the New England Journal by 3 wonderful physicians from Massachusetts General Hospital, including the first chief of ID, Mort Schwartz, that basically it was a retrospective study about 100 patients, looked at the largest series to date for osteomyelitis and concluded osteomyelitis is very bad and it leads to a high risk of limb loss. And therefore, we should be treating with 4 to 6 weeks of parenteral antibiotic therapy. And that is essentially, we think, where this practice evolved. Interestingly, because we have these really pretty robust programs in the United States that allow us to discharge patients on IV antibiotics, we haven't really felt the need to question this. In Europe, they don't have robust OPAT programs. So for bone and joint infections there, they usually will treat with IV antibiotics in the hospital and then switch to oral antibiotics at discharge. And this has been done for decades. And when we look at their outcomes and our outcomes, pretty much the same. And so there has been a relooking at this practice of IV antibiotics for bone and joint infection. But despite really good data that oral therapy, when administered correctly, dosed appropriately, works well, it still is a hard nut to crack. And some of this is related to, again, some probably flawed data around how we treat these infections. So I used to think that it was really hard to penetrate antibiotics into bone. We really thought of bone as this fortress, and you couldn't get the antibiotic in. And there was a large number of these bone penetration studies that were done that really showed that if you give a dose of antibiotics systemically, and then you go into a patient who might be having a surgery for another reason, and you sample a piece of their bone and you measure that antibiotic level, there's a big difference. We're not getting a lot of that antibiotic into bone. But what we've learned is that those studies are really fundamentally flawed. And for a variety of reasons, most of it, which has to do with those studies were not done when people had sort of steady state antibiotic exposure. And there's no data that says that you need antibiotics that penetrate bone better in order to actually effectively treat treat bone infection. There are some other concerns that I hear from time to time. One is non-adherence. Patients adhere better to their IV antibiotics than they do to their oral antibiotics. That is true. That is the case. It doesn't actually seem to matter, and I'm going to come back to that point in a little bit. But I think the real issue, why this has been a hard practice to shift, relates to our own perspectives around risk. When we're taking care of patients in the hospital and we see these devastating infections, the last thing that we want to do is shortchange them the antibiotics and prevent them from achieving a good outcome. And so we're really worried about undertreatment, but we're not thinking about the risks of the IV therapy. In our OPAT experience, about 10% of patients will have a complication, whether it be hepatitis, acute kidney injury, a PICC line infection, a thrombosis associated with their PICC line. It's not small. But we aren't thinking about that when we're thinking about choices that we're making. We're more worried about undertreatment. I also think that at times we overrepresent risks associated with certain oral therapies, particularly quinolones. And actually, quinolones, in the few studies that we do have, appear to be the most effective drugs, even administered orally, for the treatment of bone and joint infection. And yet we're afraid of them. It's not to say that we should be using quinolones broadly for patients with UTI or pneumonia if we have alternative options, but the risks associated with oral quinolone therapy pale in comparison to the risks that are associated with IV therapy. So about almost 10 years ago now, the OVIVA study was presented and published in 2019, and this is a randomized controlled trial done by a group in the UK. It was a multi-center study. They essentially looked at anyone who would have been a candidate to receive a 6-week course of IV antibiotic therapy, and they randomized them to receive either IV antibiotic therapy or oral therapy. It was a very robust study. It was done with meaningful clinical outcomes. And at the end of the study, they found that there was, in fact, no difference in outcomes between those individuals who received oral therapy and those that received IV therapy. The study was actually presented at the Musculoskeletal Infection Society meeting in 2016. It wasn't published until 2019 because the editors of the New England Journal kept on going back to the authors and saying, are you sure? Can you do another sensitivity analysis? And so they kept on doing these sensitivity analyses, including this worst case sensitivity analysis, which maybe others have seen. I hadn't seen it before at that point. But basically, if you assume that everybody who received oral therapy that was either lost to follow-up or had a protocol violation failed, oral therapy failed, and those that received IV therapy succeeded, that would be what you'd call the worst case sensitivity analysis. And even in that setting, there was no difference between oral and IV therapy. There have been multiple studies, actually. OVIVA is the largest, and none of them have actually shown an important difference, and including in meta-analysis, that oral therapy is less effective than IV therapy across a spectrum of bone and joint infections. And since OVIVA was published, there have been a number of studies where OVIVA-like protocols have been put into place. And these centers that have done these studies have determined that there have not been important differences in outcomes between those that received oral therapy and those that received IV therapy. And in addition, patients who received oral therapy had fewer complications, fewer adverse effects, no IV catheter-associated complications. They left the hospital earlier, there was a shorter length of stay, and overall costs went down. And the studies have also shown that when you screen patients, about 70% of patients with bone and joint infections would meet criteria for oral therapy. And those criteria are really quite straightforward. There is an oral regimen that's available, that's highly bioavailable to treat their infection. They can take oral antibiotics, they have a functional GI tract, and they don't have any other indications for IV antibiotic therapy. There's also no difference in treatment outcomes based on the duration of time that we use IV therapy. The OVIVA study allowed up to 7 days of IV therapy before randomization into the oral versus IV arms. And other studies that have looked at various durations haven't been able to determine that longer courses of IV therapy lead to better outcomes than shorter courses. I mentioned that the OVIVA study was presented in 2016 at this Musculoskeletal Infection Society meeting. And one of the findings that was interesting was that adherence to the oral arm was worse than the adherence to the IV arm. And, that's perhaps not surprising. If you have a PICC line in, you're probably going to, take care of it and administer your antibiotics. But Doug Osmond, who I would also consider a giant in the field, he's at the Mayo Clinic and really been a champion for advancing the study of bone and joint infections, stood up and he said, so maybe the issue isn't whether or not we're treating with oral therapy or IV therapy. Maybe the issue is we're treating too long. And, Matt Scarborough, who was the presenter, kind of had a sly grin on his face and said, that's our next study. So the next study has been presented at the European Bone and Joint Infection Society last year. Obviously, the details haven't been presented. It hasn't gone through peer review. But this study done by the same group looked at 500 patients who had surgery, had hardware infections, had surgery, had hardware removal, and the use of local antibiotic delivery, not specified other than it had to be approved in the country in which it was being used. And they were randomized to receive only 7 days of antibiotics versus the conventional 4 to 6 weeks or longer. And again, the take home, the big picture was there wasn't a difference. And so it may be that in the future, we're going to be talking about very short courses of antibiotics for patients who undergo surgery. This is an internal medicine audience. So I'm just going to close with just a couple of questions about prevention. I talked a little bit about prevention for that the surgeons use, skin preparation, drapes, irrigations, things like that. But we sometimes are asked in our practice, after the arthroplasty has been placed or at the time of arthroplasty placement, what can we do to reduce this risk? Couple of questions. One about, urinary tract infection. It used to be that we did urine screening prior to arthroplasty infection. We do know that patients with a history of recurrent UTI are more prone to develop periprosthetic joint infection. But we also know that if they're not symptomatic, treating asymptomatic bacteriuria does not make a difference. So current guidelines are just to screen if patients are symptomatic, treat if they have UTI, otherwise you can avoid the urine screening. The other is dental prophylaxis, and this is one that is just, there's the amount of time that we spend talking about this in this community, the amount of task forces that I have sat on about the question of dental prophylaxis is really quite striking. What's interesting to me is that, anytime, I think all of you said you brushed your teeth this morning, and I suspect that most of you probably flossed as well in the last 24 hours. And anytime we do that, we get a little bit of bacteremia, a little bit of those oral Viridans strep or oral flora will cross the mucosal barrier and enter our bloodstream. And yet we worry about, instead of that daily insult that all of us are facing, we worry about the time that we go to the dentist. And, when you think about the patient who comes in with a prosthetic joint infection, and maybe it's caused by a Viridans strep, which we know is oral flora, and the patient says, well, I went to the dentist 2 months ago. And we say, aha, it must be that dental procedure. There's no way to disentangle the procedure from all the other daily episodes of bacteremia. And what we've learned from studies is that antibiotic prophylaxis actually doesn't really make a difference. So we're moving away from antibiotic prophylaxis at the dentist. And I use this as an opportunity when I talk to patients about it to say, I actually don't really care if you take amoxicillin at the dentist to prevent an arthroplasty infection, but what I really care about is that you take good care of your teeth. And it is shocking to me how many people don't do that. I think in the interest of time, I'm going to not discuss sort of future areas in this field, which are vast and exciting and interesting. And I'm hoping that sometime, maybe 50 years from now, it will be a different talk where we're really able to make an important difference. But I'm going to close with a quote from Dr. Thomas Hoffman: "Be humble, as medicine is complicated and surprising." And that is certainly something that I have experienced in my career. So thank you very much. Again, it's just been a great privilege to be here.
Thank you, Dr. Nelson. That was logically presented, very didactic, clear. Don't shoot me for this question,
Okay.
and maybe you were going to get to that at the end, but it seemed to me that if the surgeons are able to give a cement that has implanted antibiotic in it, why not do that from the get-go? Why not have some sort of antibiotic locally to prevent the biofilm from forming, or in the small cases that have infection, that will be eradicated even before they become clinically evident?
So Dr. Weiss, that's an amazing question, and that is done. And so at the time of primary arthroplasty, not every patient, but many patients will have cemented devices placed, and they will use doses of antibiotics within the cement. The challenge is that if you use very high doses, it actually interferes with the cement polymerization, and that can interfere with the integration of the device. So when you're placing a permanent arthroplasty, there is a limit to how much antibiotic that you can put into the cement to really lead to that effect. Also, the elution follows what we call this burst release kinetic pattern, which means that the majority of the antibiotic is eluted within the first 48 hours, and then it sort of gradually diminishes over days to weeks. But the risk of organisms inoculating kind of continues until all of the fascial planes and the skin have healed. And so that risk of organism inoculation probably goes beyond the time of antibiotic elution. And that, of course, does nothing for the late types of infections, which are basically just septic arthritis, but in a prosthetic joint.
Thank you, Dr. Nelson. Thank you, Dr. Hudson, for continuing to sponsor today's lecture. And thank you, everybody, for finding us on the third floor. If you have some questions, given the hour, I'm going to ask you to come forward and ask your question up here at the podium.